The federal government has a new strategy to prevent suicide. It's the first time the strategy's been updated in a decade, and the agencies leading the effort say it'll be a whole-of-government and whole-of-society approach. And for the first time, the new strategy comes with a detailed action plan that lays out exactly what federal agencies will do, including some agencies you might not necessarily think of when it comes to suicide prevention. Brandon Johnson is chief of the Suicide Prevention Branch in the Substance Abuse and Mental Health Services Administration, and he's here with us to talk more. And I think where I'd like to start is if you could just start us off with a little bit of data. My sense is that's really underpinned a lot of what you're doing here, and this is not just motivated by the fact that it's been 10 years and it's time, but there are some specific reasons that inform the development of this strategy. So talk about some of that, would you?
Yeah, absolutely. I would love to get into some of that. Well, essentially, what's been happening specifically in suicide prevention, suicide in this country, is that there's been a consistent increase, really since around 2000, that there's been consistent increases in the suicide rate across the country. What we've seen really from then, and the last strategy came out in 2012, but what we've been seeing is about since 2000, it's been like a 30% increase, 36% increase, maybe overall, 30% in males and about 48% in women. But consistently, we've been seeing these increases, except for a small dip in 2020. We've been seeing consistent increases in the suicide rate across the country. I think in particularly some of the things that we found to be most striking, I think in recent years, has been this development of increases in the suicide rate among specific populations that actually weren't increasing previously. So there's been, consistent increases maintained in these populations disproportionately impacted by suicide for a long time. So looking at middle-aged white males, especially those in rural communities, looking at American Indian, Alaska Natives, looking at veterans as well. Those groups have historically been higher, but what we've seen is increases in suicide attempts among LGBTQ plus young people in particular. African American Black youth had a significant increase in their suicide rate between the ages of 10 to 24 from 2008 to 2021. And we've also seen an increase in Hispanic youth as well. So looking at this data, looking at where rates are and how things have been impacted, what we wanted to do was also address these specific things and these specific trends and increases in suicide across the country as we were putting together this document.
Yeah, and that takes us directly into one of the things that is new in this strategy, which is the equity pillar. Talk us through some of the thinking behind that, and what are the reasons why you specifically target equity in a strategy like that? Is it that, some of the policy interventions that we have in place and know how to do just were not serving these communities?
Yeah, I think there's a mix of two things. I think generally speaking, one of the ways that we've seen, we really wanted to look at what advancements have we had since the last strategy. And I think this idea of more targeted suicide prevention activities versus those that are universal, a really good opportunity to speak directly to the risk and protective factors, the societal challenges, the unique community aspects of some populations that I mentioned previously where we're seeing trends increase, but also looking at those groups that have been disproportionately impacted and some groups that have been left out of the conversation. So we really wanted to have an opportunity in this strategy to look at how to incorporate health equity in suicide prevention. So how do we look at data and trends in these various populations and really assess what are the risk and protective factors there? How can we intervene that meets the needs of these specific populations? And then how do we include them in the work? So not just, developing a program or intervention that says, we think this will work for this population, like it'll speak to them, right? I think really doing what I call really good public health work and engaging the community in the prevention strategies, in the development of interventions, and really having those conversations and developing these things in tandem with the resources that we have that can really speak to what's driving the suicidal behavior within these populations. And then looking at a community such as those with developmental disabilities or other disabilities who haven't necessarily been at the forefront in the minds of folks in suicide prevention. This gives us an opportunity to identify those groups and understand if, we're not looking at the data with these groups, then why aren't we? Are we not collecting it? Do we not know? And how do we improve our overall data systems to engage these populations. So really the health equity section goes into details on all of that. It calls out specific groups and populations that we should be thinking about, and also how do we accomplish this as well.
And then I wanted to talk about some of the specific roles for federal agencies under this action plan. I think there's 20, maybe more than that, involved here with different roles. And I imagine that's kind of a complex mix, right? Because I'm guessing you've got some like DoD, VA, IHS that have more of a direct provider. They're directly touching patients' role in the behavioral health system, and some others that are a couple steps removed from the individual. So talk about some of the specific things that different agencies are going to be doing depending on what their missions are.
Yeah, I think and just so folks are aware about the federal action plan, this was a one of a kind document that we were able to put out in tandem with the strategy, where our federal agencies, I think there's close to around 29 federal agencies, 10 federal departments that were able to really add some action items to this. And so we have over 200 action items that federal agencies are taking to advance the goals and the objectives, which is really exciting for us. And so in terms of kind of where agencies are looking at as a part of this, I think in this process of developing these action plan items, when we were working with the federal agencies, what we wanted to do was, encourage them to really focus on populations that they serve, regions that they serve, where they have kind of work already happening with specific populations, and how do we take that to another level and kind of do some innovation as well. And so in this, I think the actions across the different agencies, like you said, it really does vary. So if you look at the Indian Health Service, for example, like one of their goals was specifically around universal screening, suicide risk screening across all of their healthcare systems and their facilities. And so as we look at that, they have reached down to the ground at the local level within tribes, tribal communities, tribal nations, to really do this work at that level. So implementing universal suicide risk screening across these populations really gets to the level of the work that they're doing and being able to reach that population. If you look at USDA, one of their action plan items is around supporting mobile crisis teams throughout rural communities and how to disseminate information there, because that's where they have their reach. And so they're able to improve that service within rural communities because of it's an opportunity and a place that they're already working. And if you look at, some action items from us at SAMHSA, we're really talking about engaging state suicide prevention coordinators that we have major relationships with as we're doing this work, and really trying to get things at the state and the local level, because a lot of our grants are serving at that level. So we have an action plan item that focuses on disseminating practices that speak to risk factors and social determinants of health related to suicide prevention. And how do we take that and tailor it for states and communities and get that information down to them, and also help them with materials that they can use and create to actually advance the work in this area. And, you take an NIH, and they are definitely talking around the research end, because that's their lane, right? And so I think looking at this and looking across the action plan items, I think you'll find a really healthy mix of action plan items. Some are a little more broad in like the research space. Some drove down to local communities with like IHS, but it really kind of varies across all the federal agencies. But I think we really got a good mix there. We have action items across all of the goals within the strategy. So this is really an opportunity to kind of address suicide across a number of different fronts, with all of our agencies really kind of thinking about where can they have the most impact. And we're hoping that all of this work collectively drives a decrease in suicide rates.
Super interesting. I never would have guessed that a USDA, for example, has a role in suicide prevention. I'd like to talk about how that kind of thing adapts over time. 10 years is a long time horizon, right? I'm sure it was hard enough to get everybody on one page as a one-time event to develop one strategy. How do you make sure this flexes as it needs to during that 10 years as you learn more and more about what's working and what's not?
That's a really great question. And so what we did was that we really wanted to address that very thing that you brought up. So the strategy itself is a 10-year strategy. So the strategy will be in place for the next 10 years. The federal action plan is around for 3 fiscal years. So at the end of the 3 fiscal years, we're kind of assess really where we are with the action plan items. And so if there are needs to pivot or needs to kind of take some action items off,